we're very happy, as I said, very happy to have Dr. Samee here with us today, and in general here with us in Emporia. So we're going to turn it over to him, and I hope you'll welcome him.
Thank you very much. I want to tell you is I'm not a good speaker, so that I don't get embarrassed. So this is first time I'm talking. Can you hear me at the end?
You talk a little louder, please.
Okay, good. Can you hear me at the end now? Wonderful. Okay. My name is Samee, and Charlie is my office manager. So I wanted to introduce her to you guys. Anybody who will come to see me has to go through her. So, they asked me to introduce myself and tell you what I did in my training and everything. So I can tell you a short version of that. After my medical school, when I started training, I started from New York. So my total number of training years were 11 after medical school, actually 12. So I did 1 year of general surgery first, then I switched to internal medicine, did 3 years of internal medicine in St. Louis, Missouri at St. Louis University. And then I went to Mayo Clinic where I did 2 years of NIH fellowship and master's in clinical research. From there I went on to University of Connecticut where I did 3 years of cardiology training. And after cardiology, I did interventional cardiology training where we put stents in the heart. After that, it was not enough, so I thought I should do more. So I did peripheral intervention training where I put stents in the legs, kidneys, arms, anywhere, wherever it is required. So that's my whole training that I did. So I'm trained to do echocardiogram, transesophageal echoes, intervention, cardiac catheterizations, and of course, seeing patients in nuclear stress tests. So we provide most of the services here in town, and we cannot do all these things here because we do not have a cardiac catheterization lab. So people who will need cardiac catheterization, we will go to one of the Richmond hospitals. So I go to Memorial Hospital, St. Francis, Petersburg Hospital. Those are the 3 major hospitals there where I go. So if you guys want to go to any other hospital, we can arrange that too. Me and my partners also go to Chippenham and Johnston Willis Hospital. So if there's any preference, somebody wants to go to one of these hospitals, we can arrange that. So in the past, I know you guys were going to different places, but we are trying to bring everything in town so that you guys don't have to travel. I understand there's a lot of traveling involved when you go to Richmond or you go towards North Carolina. So the plan is to bring people here, including electrophysiologists at some point, so that they can come once or twice a month and see patients here for like 1 year. So that's my introduction now. What I want to talk about is basically I will answer any questions you guys have today. There's no formal talk today because it's the first time, so it's kind of introduction thing. So if you have any questions, I'll be happy to answer. So yesterday the weather was so bad. So yesterday the weather was so bad. I'm going to tell you what my daughter told me yesterday. When I got home, it was raining and it was lightning. So she asked me a question when I got home. She said, when there's lightning, why do we see light first and then, here? Does anybody know the answer to that?
Light travels still the vacuum.
Light travels fast.
My answer was I don't know. And she gave me the answer. He said because eyes are in the front and ears are in the back. Yes, you have a question.
I do.
Yes.
What is an electrophysiologist and what do they do? What can
So there are different kinds of cardiologists. Some cardiologists just are general cardiologists. So the number of years of training they will go through are 3 years. Then there are plumbers of the heart, like I am a plumber. So I open the arteries if they are blocked. Okay? So we call ourselves interventional cardiologists. So if the artery is blocked, we can go from the leg or hand and go in the heart artery and put a balloon and a stent inside the arteries. So those people are called interventional cardiologists. Then there are third kind of cardiologists called electrophysiologists. They are electricians of the heart. So if somebody has electrical short circuiting or needs a pacemaker or ICD, so those people go to those special kind of doctors. So all of us are cardiologists, but then they are specialized training after a basic training. Did that answer your question? Good. Eventually, yeah, that's the plan in a few months. But you know, we are planning to do basic stuff here first, and then people who have blockages in the leg arteries, we are planning to start here in the hospital, start looking at their legs, doing angiograms here. So that will be something new that we'll start here. And it's a small catheter that goes to the leg, and we can shoot dye and look at the leg arteries. If there's a blockage, we can open by putting, again, balloon and stent and rotor-rooter. But initially, we'll start that part in Petersburg. Then eventually, we'll start here. But that's the, step number one. Yes, ma'am.
The carotid artery.
Is it?
The carotid artery.
Carotid artery ultrasounds we do, but not surgeries. Generally, surgeons do that part of it. Sometimes interventional cardiologists put the stents in the carotid arteries. I can do it, but I don't do it regularly, so I choose not to do it if I'm not doing it every day. Any other questions? Yes, ma'am.
Do you need a referral, or did someone just make an appointment?
Somebody call and make an appointment anytime. That's why I brought Charlie here so that you guys can, see her and talk to her also. If you need to see me, call Charlie right away and we can accommodate you.
I'm a patient of Dr. Katrina, and I didn't get anything that she was gone. So, what happened to my next appointment?
Yeah, same thing. Same appointment that you had before. So you can come to your appointment and I'll be happy to see you. I thought hospital sent some letters out to all the patients. And told them to come and keep the same appointment.
They said because it was right.
Your appointment with Dr. Katina, that time is still set. It's just transferred over to Dr. Sammy.
Yes, ma'am.
If you were going to have a valve replacement, could you explain what type you have and the difference?
So it depends which valve we are talking about. There are two valves that we generally replace or repair. One is aortic valve and the other one is mitral valve. Let's talk about mitral valve first. Mitral valve is the valve that is between upper chamber and the lower chamber of the heart. And if you need to get replacement, then there are a lot of factors come into play. For example, if number one is the patient's choice. If you say that I want to get a metallic valve and I'm okay with Coumadin, then we put a metallic valve in there. If somebody says that I do not want to be on Coumadin for a long time, then we put the other kind of valve, which is porcine valve, which has material in it. It's an artificial material, or we can put a pig valve in it. So those are the two major type of valves that we put. Now some young girl who needs to get pregnant, we do not put a metallic valve, because then that person has to be on Coumadin for life, basically lifelong. So we put the other kind of valve where we can stop Coumadin in 3 months. The aortic valve, it's a similar kind of thing. One more thing with the mitral valve. The mitral valve can be repaired rather than replaced. So we can just put some sutures and repair the valve. So that is our first choice, to repair the valve. If you repair the valve, then it works normally like normal valve. Then you don't need a new valve. Unless the valve is so much damaged that we need to put a new one, we don't put a new valve nowadays. For aortic valve, generally we do replacement. We need to put a new valve there. Because aortic valve is between the lower chamber of the heart and the aorta, which is a major artery that comes out of the heart. And that's where we need to put that aortic valve. And for that you need to be accommodated lifelong. It's very difficult to repair that. Some people are repairing it nowadays, but it's very difficult to repair. But the repair or replacement nowadays is getting easier for the patients because now we are doing robotic surgery with small incision rather than opening the whole chest. With small incision we can replace the whole body. So technology is getting advanced. Now a step forward, a lot of people who are not candidates for valve replacement, we can also do the same way like we do angiogram, go from the leg and put a new valve in the heart. That's just the aortic valve that we can put the valve. Does that answer your question?
Another question, could you explain to us what AFib is?
Yes.
And why we have it?
Why we have it? That's actually a great question because nobody knows. A lot of people have AFib. It's electrical short circuiting basically. And a lot of people have atrial fibrillation. It is basically the upper chamber gets so big that generally heart has a brain. Okay? So it's a small brain inside the heart, and that gives a signal to beat. So what atrial fibrillation is, heart becomes so big that there are different directions, from different directions, that signal is coming down, and the heart is going crazy and beating so fast that people start, feeling palpitations or pass out or different symptoms. Now it's very difficult to control, those signals that are coming from different places. So either we can block it with medicines or sometimes we can do ablation. Ablation is basically we cut that pathway with a laser. So those are the treatments how we can treat it, or we can give medications to control the rate. But atrial fibrillation is a difficult problem to deal with. Because what happens is upper chamber is not pumping and the lower chamber is pumping normally. So what happens in upper chamber, you develop clots. So that clot can go to lower chamber, and the lower chamber, function of the lower chamber is to pump the blood. So the clot goes there, that can go to your brain, to your leg, and you get a stroke. So that is a major problem. That's why you put people on Coumadin so that they don't develop clot in the upper chamber. And it's better to stay out of that atrial fibrillation. And nowadays technology again is advancing so much that we can, cut all those pathways and get rid of atrial fibrillation. You don't need to get an atrial fibrillation if you don't. With medication we cannot control it. We can do it mechanically and cut the pathway. A little cumbersome, but can be done.
What should be done to tachycardia?
Tachycardia is basically fast heart rate. And there are different kinds of tachycardias. So there are 100 kinds of tachycardias. So it depends which kind of tachycardia somebody has. If it's atrial fibrillation and heart is going fast, it's called tachycardia. So tachycardia basically means fast heart rate. So if a fast heart rate is because, for example, if somebody starts vomiting or has a fever, heart will start beating fast. That's also tachycardia. But to treat that tachycardia is to give antibiotics or give fluids or Tylenol. That will take care of the tachycardia. But then there are dangerous kinds of tachycardias like atrial fibrillation, where we have to give stronger medications or cut those pathways with mechanical devices. Ventricular tachycardia? Okay, ventricular tachycardia is basically lower chamber of the heart is going crazy. In atrial fibrillation, upper chamber of the heart is going crazy. Here, the lower chamber is going crazy. So what happens when lower chamber starts beating very fast? Ventricular tachycardia is the most dangerous kind of tachycardia because people die from that. Anybody who has a heart failure and you heard somebody died, they died from ventricular tachycardia. Your heart goes into ventricular tachycardia, then next stage is ventricular fibrillation where it's not pumping at all. And that's the end of it. So ventricular tachycardia, we have to treat it one way or the other. So there are different treatment options, medications. We need to find out what's the reason for ventricular tachycardia. If the coronary artery is blocked, and that's why you're having ventricular tachycardia, we need to open the arteries by bypass or by angioplasty or stent placement. So we need to find out what the reason is why somebody has ventricular tachycardia. Sometimes with a high blood pressure or sleep apnea, your heart becomes so weak that it's not pumping and it's pumping like 10 to 15%. And at that point you can develop ventricular tachycardia. So the reason is the main thing. You need to find out what the reason is. Yes, ma'am.
You will have inherited a patient with Dr. Chiquino who has not seen you yet.
Yes.
August the 1st appointment. You will be checking pacemakers, is that correct?
Yes.
If the primary care physician sends you any lab results that need to be evaluated, will you look at those before they put in the patient record even though you have not seen them?
Yeah, I'm looking at it. So I'm already looking at all the things that are coming back to me from Dr. Chiquino, things that she has ordered or the labs that other doctors have ordered. They come to me, Charlie keeps them out, and I go to the office and I look at all of them before I start seeing patients. So I'm looking at it right now, and if I need to see those patients, I'll write down, let's follow up with these patients so she can bring them over.
Where is your office?
It's Dr. Chiquino's office right now.
You're taking her place.
Yeah, right now I'm in the same office till we get a new place.
Coumadin, what is the side effects, adverse effects of Coumadin?
Coumadin, bleeding. Bleeding is the major side effect of Coumadin.
What?
Bleeding. So we can bleed.
Oh, bleed.
Because it's a blood thinner, if the level is more than 3, then the risk of bleeding is very, very high. So think about it, if you cut yourself, you can bleed. If you fall, hit your head, person can bleed. Or if, there's an aneurysm in the brain that can rupture. People bleed all the time if, we cut ourselves. The problem is the blood will not stop. Stopping is a problem. That's the major side effect.
No clot.
Sorry?
No clot.
No clot. Clot, yeah, it works against clots. Nowadays there are new medications, Xarelto and other medications that we can use for atrial fibrillation where you don't have to use Coumadin. The problem with Coumadin is you have to go to the hospital or the clinic to make sure the level is within the range. Then you cannot eat this wonderful food that you're eating today, all these green vegetables. So there are a lot of problems with the Coumadin.
What is an abrasion and which type of cardiologist?
Those are electricians of the heart. As I said, electrophysiologists, they do ablations. So ablation, basically, they go in from the leg and put a small catheter to the heart and cut that pathway extra short circuiting which you have it in the heart. So they can just cut it with a laser. It's a painless procedure. You don't feel any pain. Yes, sir.
Do you live locally?
I don't live locally. I'm actually moving. So I just sold my house yesterday. So I'm planning to move this way, closer to this place.
What happens in the middle of the night after you move and the person has a heart attack and goes to the hospital?
So if somebody has a heart attack, we cannot do interventions here in the hospital anyways. So they have to move people to Petersburg. I'm on call in Petersburg, either me or my partner is on call in that hospital all the time, 24 hours. So if somebody is having a heart attack, they will call me directly, and they've already done it a few times already. And ER doctor knows about it. They will call me, they transfer the patient to Petersburg, and we will meet them in the emergency room and do cardiac catheterization and angioplasty emergency. At the room. Yes, ma'am.
How many days a week are you working?
5 days a week. Right now till middle of July, I'm 4 days a week here, and then my partner is going to come here too. He'll be here on Fridays, so we'll be covering it 5 days a week, and I'm on call 1 weekend a month. So once my partner will get the privileges, everything is all set, then he will be coming here too. So we are providing more coverage than before, and we are on telephone call away for 24 hours a day. So any problem, doctors from here, they are calling me even when I'm at my home, and we're transferring patients who need to be cath or anything needs to be done emergency. as I said, we're trying to extend the services here so that we don't have to run around. And if something we cannot do, that I don't do surgeries, so we'll definitely send you to the best person who I think is best enough for you.
Any other questions?
Yes, ma'am.
Question?
Yes, go ahead.
I raised my hand.
Yeah.
Yes, ma'am.
What does a patient do what do you do with someone that has the main left artery on the right side?
Main left, you mean congenitally if it's on the right side? It depends if it is blocked or not. There are different things we need to figure out in that case. Number one, if it is blockage that we are dealing with, then we need to open the blockage. First thing we do is do a CT scan of the heart to make sure that the artery is not going between two major arteries. That can clamp that artery. So if it's not clamping, then we are fine. If it's clamping your major artery, then surgical option is the best.
I'm fine then.
You did.
I have that. I found it out when I was 59.
Okay.
And Dr. Ethan is my heart doctor. And
He did the same thing?
Huh?
He did the same thing, but I just...
No, he found it when he did the catheterization. And he said he was going to go to the other heart doctors and talk about this situation. I said, don't mess with anything, don't be fixed yet.
Right.
I said, I lived 59 more years with it like this, so fine. But I just wanted to know if you had something. He mentioned that to me.
Yeah.
But I'm safe.
That's good. Yeah. If nothing happened for
I just wanted to
69, 59 years, it'll be okay. That means it's not pinching, it's not.
And I have a strong heart.
Yeah, you've heard these young athletes, they die while they're playing. So many of them have these kind of problems, congenital problems, and they don't get enough blood to the heart muscles. They die young. If you made up to 60 years, you're okay.
He keeps check on me.
That's good.
What is your normal blood pressure?
Normal blood pressure is 120/70.
Mine was 119 over 70 last night.
Wonderful. Beautiful.
No medications.
No medication? You're doing something right. Your wife must put the good food.
Don't have one.
Huh?
Don't have one.
You don't have one, okay. That's why your blood pressure is fine. I didn't say that.
You got the doctor right there. He knows his stuff.
I need to check my blood pressure.
That's why you're doing it. You asked me and I told you.
That's
Any other questions?
Both readings are below 100. 90.
It depends if you're taking medication. You must be taking medication that your both readings are below 100. So that's medication effects. So what we then need to do is adjust your medications. Because upper level should be above 100. Some people tolerate it well, and then some people will keep it below 100 or around 100 if you have a heart failure symptoms. And it is acceptable. If it is below 70, 70 is a magic number. We don't want to get to that point anyways. We always want to keep it around 100. If it is below 70, then it's very, very dangerous. Then people, sometimes don't survive. But 100, 90, you will be symptomatic if your blood pressure stays like that. Again, it's individually, it depends on the individual. Some people who have blood pressure of 200 normally, they don't take any medicine. We don't want to bring it down to 120. Because 120, as I said, is normal, but it's not normal for those people because bring it down, it's like 80 points down, right? That can give you stroke. So we have to be very careful, whatever is the baseline reading, and then bring it down slowly. So it's different in different people. That's why sometimes you hear, yeah. Sometimes you hear from people, the doctors, they say, your blood pressure is 140, it's okay. And you think, the other person's blood pressure is 100 and he said the same thing. but the reason is different why we say it. Yes, ma'am.
Some of the symptoms of a heart attack. Now, I know some of you go to the arm,
it's different in men and women. So men presents generally with a typical heart attack symptom. It's a chest pain in the middle of the chest, it's grabbing the chest, it's going to the left arm. That is a typical symptom of chest pain. And it is not sharp pain generally, it's a pressure or tightness in the chest, or an elephant sitting in the chest. That's typical for heart attack symptoms for men. So women present differently. Women, they present with back pains, jaw pain. I had a lady who had a tooth extraction after she had jaw pain and still had pain. So we took her to the hospital. She was having a heart attack. So we can present differently. Neck pain, shortness of breath. So they're different. That's why it is very common to miss a heart attack in women, because once they come to the hospital, people think there's a back pain. They give back pain medication and they don't go. So we are very careful when some woman comes to the hospital or to the office and they present the atypical symptoms. We order the stress test. Sometimes women ask me, I don't have the typical chest pain. Why are you ordering stress test? But this is the reason why we order, because women don't present with the typical symptoms. So it's different for women, men, and women. And then age is another factor. So once we are more than 65 years of age, the symptoms can be different. So it can be feeling weak, fatigue, and then just shortness of breath. Similarly, if you have, for example, pneumonia, people don't present with fever if they have pneumonia. They present with fatigue or malaise, or don't want to get up in the morning. So the symptoms change. That's why there's a whole field of geriatric medicine where we just study geriatric medicine. Geriatric means, people about 65 years of age.
Thank you.
Any
So
other
who knows what is the age limit for old age? What is the limit for old age? At what point we say we are old?
Next year.
Next year.
That's a good answer. But it's after 90. There's only one more question here, right?
Doctor, 2 weeks ago, my blood work was excellent.
Wonderful. Good, very good. So all of you are very young. Very good. Young and good looking.
Except for
That's
you.
it.
I know why your stuff is so good.
Why here?
What is that?
Just keep it to
I'm
yourself.
going to leave you alone.
Yeah, you should advise us. We can.
And she works out in the yard. She walks.
Very good.
I walk 2 miles. I get short breath sometimes.
That's good. At your age,
I
you
don't
can
take
do
any
it.
blood pressure medicine. Nothing in my heart.
And what did you say you walked 2 miles?
2 miles.
I don't know if
That's,
everybody heard that. This is
all of us, you
the
should walk at least
91-year-old
2
that's
2
telling
miles
us
at
that.
least. So a lot of women, they tell me we exercise a lot, and I ask them, how do you exercise? They tell me they work at their house and they do so much work in the house. It's a lot of exercise. That's not exercise. That's called fatigue. So exercise means you go out and exercise.
If you've had a silent heart attack, what are the chances of a reoccurrence? Or what do you look for?
A lot of people have silent heart attacks. 19% of population have silent heart attacks that you don't know that you had a heart attack. So when we look at the EKG or do the stress test or something, we look at that and say, well, you had a heart attack and you never knew that. Because a lot of people who are diabetics, they can't feel chest pain. So one day you get up, you're not feeling well, you call in sick. You call in sick and you stay at home that day. And you're lousy all day, next day you start feeling better. So 3-4 days later you start going back to work and then you improve in a week. So you probably had a heart attack that day. So those things that people don't know about when they had a heart attack, they didn't have chest pain. So they didn't think about the heart attack. So what we do for that is how we can find out is the stress test, echocardiogram, ultrasound of the heart, and then nowadays we can do MRIs, cardiac catheterization to see if their heart arteries are blocked. But the thing is, if your heart arteries are blocked, we can open them and that can bring your heart muscle back even if it is not working fine. So doing all these things, the purpose of doing anything that we do in cardiology is to save your heart muscle. So once the heart muscle is totally damaged, we cannot revive that. So opening the heart arteries, treating atrial fibrillation, all these heart conditions that we treat is because we want to save the heart muscle. So earlier the better. That's why when somebody is having a heart attack, we have to open the artery within 90 minutes. The time somebody started having chest pain, till I open the artery has to be within 90 minutes, no matter where you are in the country. So if somebody comes to the emergency room now having a chest pain, or the middle of the night, they call me, I run to the hospital, they transfer the patient from here to Petersburg, and we take the patient right away to the cardiac catheterization lab and open the artery, and it has to be within 90 minutes. So we act very fast. So that, because we want to save the muscle. After 90 minutes, the muscle will not, we can still save it, but not exactly how, its time is muscle basically. More we wait, more damage it will cause.
Does alcohol have an adverse effect on your heart?
Yes, it depends how much you drink.
I mean, 4 or 5 drinks a day.
4 or 5 drinks a day. It's an interesting thing because studies have shown that if you drink 2 drinks a day, and it depends where you are. If you're in Wisconsin, 2 drinks a day is big. Drink is like it. Yeah. So 2 drinks a day has a cardiac protective effect. That's what the studies have shown. But I have published a paper and presented in myself when I was at Mayo Clinic. So I presented in American Public Health Association conference, in which I showed that even 2 drinks, people who drink only 2 drinks, their mortality still is higher than normal people. The reason for that is those people die of suicide, homicide, car accidents. In other words, their heart is healthy, but they die. That's the problem. So it depends if you want a healthy heart or life, you have to choose.
Well, I know it.
5 is too many.
5 is too many. That will actually, 5 is too many. That will actually does 2 things. One is it will kill you fast, and people die with a bad heart. With 2, people die with good heart. Here you die with a bad heart. That's the difference. So heart starts getting weaker and weaker if you drink a lot.
Switch to tea.
But generally, as far as medical studies go, generally they say 2 drinks are especially wine, is good for your heart muscle and heart.
How about smoking?
Smoking there's no benefit to smoking, right? But there are 2 benefits of cigarette smoking. Does anybody know?
Smoking?
Is it any particular food you eat or don't eat?
Yeah.
High cholesterol diet, is bad for you.
I want to know
Anything
that
with
you
high cholesterol and when you So smoking, he asked about the smoking. So smoking is very bad for you. It causes heart attacks, throat cancer, prostate cancer, gut cancer, tongue cancer, and dementia. A lot of problems smoking can cause.
What are the 2 benefits? Young
Oh,
corpse.
no, one benefit is you never get thieves in your house if you smoke. You never get robbers in your house.
Why, Robert?
Because you cough all night, they think you're awake. The other benefit is people don't end up in a nursing home. Second benefit is you don't end up in a nursing home. You know why? Yes. But there's no. Actually, people, I'm kidding aside, but people who smoke and if they have Alzheimer's, they have done well. But they do well if they have Alzheimer's.
They do.
Yeah. I mean, that's what the studies have shown, but we still don't recommend it.
So we start smoking at an old age?
Start moving.
I think we had a question back
Yes.
here.
Somebody has question? Yes, ma'am.
My husband died, had a heart attack, we had his last meal on the 12th of March. And they said his heart was
Yeah, sorry?
A widowmaker.
Yes. So she's asking her husband, Pastor, I'm sorry to
He
hear
never
that.
said he had a pain or anything. I just looked over and he didn't look right. And then he kept a noise and was his last breath, you know. And I brought him on here. They broke into, they shot him 3 times against him. Flew into Richmond, high school, and killed. Like that was Tuesday night, and on Monday, they showed us that he had been brain seizures, stamps, his him, but his name was John. So they took all of his life support off. Breathed all night that night on his own, but the next morning, I said, we went over to him, they gave him Dallas and when they started to move him to a room where they said that they could put him for 2 days, and we have to find us for 7 days. They came back in there and said, come back quick, I don't think he's going to make it. So that was really hard.
So, very sorry to hear that about your husband. So basically what happened is there's an artery that comes in front of the heart. It's called left inferior descending artery, or LAD. You probably heard, many of you probably heard about that artery. That is a major artery that comes in front of the heart. If there's a blockage at the upper portion of that artery, that area is so dangerous that if it gets blocked totally, people don't survive. We call it widowmaker. And what happened basically with your husband is, you were talking about ventricular tachycardia, ventricular fibrillation with heart, lower chamber of the heart is not beating, fully. So when that starts happening, then we have to give a shock to bring him back. Or any person who has ventricular tachycardia.
He never said he had a pain or anything.
Yeah, because once you go into ventricular tachycardia, you don't feel pain. People don't feel pain. It's probably, in his case, I would tell you this is probably blessing in disguise, because he didn't feel any pain. Otherwise, this can be a painful procedure. If somebody, Lord wants us, this is the best way that we don't feel any pain, and we go and meet with the Lord. I think this is a painless procedure when this happens, and especially when, as you said, brain was not working. They don't feel any pain or any suffering. They're not going through. So you should have peace of mind that he did not suffer.
Any other questions? Well, we sure would like to thank you for being here today. We certainly enjoyed it with you.
So next time we'll have a formal lecture if you guys want. If you have any topics in your mind, let us know. I can come and give you some slides. We can all learn.